Hello and welcome to another episode of the Young Tongues podcast. My name is Barbara Fountain and I am the founder and CEO of the Young Tongues, a peer-to-peer support group for young tongue cancer patients. Now, I am delighted to bring you another expert guest this week. I am joined here today by Dr. Alexandra Kejner. Welcome to the podcast, Alexandra. Lovely to have you. You are a head and neck surgeon from South Carolina, and we love to get to know our guests a little bit beyond the profession. So would you mind introducing yourself to our audience? Who's Dr. Alexandra Kejner?
Well, thank you so much for having me. This is an absolutely wonderful endeavor that you've undertaken, and I massive applause. So thank you so much again for having me. So yeah, I am in South Carolina. So if anyone is familiar with that part of the country, we are in the very southern part of the United States. I actually am not from here. I'm now on my 13th state. So you can imagine kind of like if you were bebopping around all of Europe. So it's been a really fun time. I've got to see lots of different parts of the country. My family's originally from Argentina. So they came here in the 70s, all the time of the disco and everything. Now I've been in South Carolina about almost 3 years and live here with my husband, and I've got a little girl who's 4, who's an absolute doll baby. I just want to chew on her face. She's so cute. And then my mom also stays with us, which is really lovely. I'm incredibly spoiled, but it's one thing to be a 42-year-old and have your mom be like, "I'll make you some lunch for work." I'm like, I will take it. Yeah, I would never turn that down. So, very, very blessed. And I enjoy going outside. It's one of my favorite things to do, even in terrible weather. And staring at birds. I think it's a middle-aged thing that you go from being like, oh yeah, that's a bird, I'm like, oh, that's a red-bellied robin. Look how beautiful that is.
Yeah, mid-30s it hit me. I was like, oh wow, that bird is incredible. I need to look up what it is.
And I'm like, that's a heron. I love it's a night heron, so it's gorgeous.
South Carolina, it's on the coast, isn't it?
Mm-hmm. Yeah, yes. It's so beautiful, absolutely beautiful. It's kind of got some marshland as well, so we do get a lot of the water birds, the herons, the ibises, the egrets, and it's just beautiful. Some beautiful sunsets.
That's lovely. I'm just familiar with that region, shall we say, through rom-com movies.
Oh yes. Actually, yeah. So the Notebook was filmed about 20 minutes from me.
Oh my God.
Yeah.
It's so beautiful. Okay. I should be coming for a visit.
Absolutely. I love it.
It goes on my travel list. So Alexandra, you are a head and neck surgeon. Mm-hmm. Now, what inspired you to go down the medical route and then pick that speciality? And I guess give us a little rundown of your bio without being too technical about it, I guess.
Oh, yeah. Well, I don't think there's a whole lot technical about it. It's interesting. The majority of our family, almost everyone's in engineering, so which is funny because I'm very much the other side brain, whichever one it is, I can never remember. But the one of the things that I really, really enjoyed, even from when I was a little kid, I think there was a show called Mr. Wizard. And I don't know if you've ever heard of that one. It was a science show on television. And, I really loved the whole, just all of science. Science is just so neat. There's so many cool things. And then I got to see a live surgery. I have no idea how I was allowed to watch it at all. I'm sure it was something on PBS. I don't know. But it was absolutely fascinating. And so I knew from very, very young that I want to be a doctor. And my parents were like, are you sure you don't want to be a dentist and have a nice life and, have, no call? And I said, no, I'm going to be a doctor. And so initially,
I also feel like if you get exposed to watching surgery and you can stomach it, you kind of you found your calling. There's not many people who can do that.
Like I can't see a kid with like a snotty nose, just like if they eat, oh gosh, blah, blah, blah. Like that'll give me the willies. But yeah, if someone's getting cut open, it's like totally fine. I know it sounds strange, very, very macabre, but yeah. And I was initially going to do neurosurgery, and during our medical student rotations, there's a lot of interplay between neurosurgeons and otolaryngologists or ear, nose, and throat doctors because a lot of times we get them to the brain or to the spine. And I realized I really liked that part of it more than the actual brain surgery because of all of the human part. I mean, all of it's human, right? But and as you know, as a survivor, all that we do in ENT, it's like it's the front facing part, right? It's your speech, it's your swallow, it's your talking, it's your breathing, it's how does it look. That's the first thing people encounter when you meet them. And so that part to me was, absolutely I was like, that's what I gotta do. First I was I'm gonna do cochlear implants. I'm gonna give the gift of hearing. And then I saw a neck dissection and I said, never mind. This is so beautiful. This is beautiful.
As someone who didn't know what a neck dissection was 6 years ago, and having now seen a video of it,
oh gosh, yeah.
it is actually well, it's not something I would have wanted to see 5-6 years ago, but now it is very fascinating, and it's such a I can't get over the skill set in terms of having such a steady hand to operate on something so small. And seeing the right, so yeah, okay, I totally.
Well, we have cheaters though. I always tell people I have
okay.
I have these like magnifiers that they're 3.5 times magnification, so it makes it. Oh, but it's really so if you like peeling a hard-boiled egg, you get in the right spot and you just kind of get it in that. That's kind of how operating in the neck feels like, especially when it's like really it's so pretty. And it looks like the books. Like, you get the little anatomy book out and it actually, unlike the belly and other places, it just matches. It's so beautiful. Yeah.
So in terms of your role in the operating theatre, and I know there's going to be regional variances, but in the US. So we, especially when it comes to tongue cancer specifically, so we have a whole team of different surgeons in the room. Now we have something in the UK, we call it the maxillofacial surgeon, who I think is in charge of the tongue. And then we have different surgeons within it who do different parts. So which part are you, so to speak, to fit into the team?
Yes, it's a little, it is a little bit unique. I think in the US we do a combined fellowship. So I did a 5-year residency. So that's where, or registrar it would be in the UK. So that's 5 years where I'm learning just straight otolaryngology. So all of the different parts of it. So, otology, which is the ears, rhinology, which is the sinuses, laryngology, which is voice, swallow, speech, and then also head and neck. So, which is kind of a funny name for it. Like, oh, head and neck. It's like, oh yeah, I'm like a thumb and finger person. But head and neck encompasses a lot. So in head and neck, subsequent to that, we actually also have a subspecialty that you can do, which is an extra year to 2 years of training. And during that time, we actually do 2 parts. So one part is called the ablative, meaning you're taking out tumor, extirpating tumor. And so in the States, both otolaryngology and MaxFax can do it. So like one of my very best friends, it sounds kind of funny, I'm one of my very best friends is a MaxFax. So he's lovely. And so we oftentimes will pair up. And so both of us can do the ablation, meaning the removal of tumor, and both of us can do the recon. And so we do it almost like at the same time. I don't know if you're familiar with NASCAR, when they go in, they get all the wheels off, or Formula 50.
Yeah, or Formula One.
Formula One, that's it.
Yeah.
And you're taking the wheels off. So it's sort of a similar concept, is that especially if we're doing a larger reconstruction, it'll be 2 teams working at the same time. Often in otolaryngology, it's actually both teams are otolaryngologists. It just depends on kind of the setup in that hospital setting. So I do both. I kind of wear both hats. And it's nice because it keeps the resecting surgeon very focused on, okay, this is the cancer part of the operation, while the other person is like, this is my reconstructive part. So for instance, like let's say if it's a jaw cancer, I might be the person taking the jaw cancer out, or I might be the person reconstructing it. And so it kind of depends on how it's been scheduled, which I know sounds kind of strange, but it's a nice balance.
Yeah. Do you find there's some variance within the US in terms of different healthcare settings do it slightly differently? Because I'm just really interested in general, because we're a global community and we speak to people globally, we are seeing the nuances in terms of different practice. Not saying one is better than the other, but it's just all like sometimes a bit different. I wonder if that happens within like the United States, being such a big place, within that infrastructure as well.
How many countries in one, right?
Yeah.
No, yeah, it's very different. And interestingly enough, so I've been practicing almost 10 years now, and I've been in 3 different institutions as a job, and then also I trained in 2 other places. So I've kind of got to see different sort of themes and trends. So for instance, when I was at the Medical University of South Carolina, we have, like, so let's say I meet a patient and they have a tongue tumor and it's invading into the jawbone with lymph nodes. I usually will set them up for their resection. I have them meet the reconstructive surgeon the same day, as well as our maxillofacial prosthodontist. And so the prosthodontist is the one that he's lovely. Oh my gosh, you should totally get him on your He's like one of my favorite people. But he makes all of our teeth, noses, eyes, ears. And he's embedded in clinic with us, and he comes to the operating room with us. So if we're going to plan on something, I have them meet him and meet our reconstructive surgeon. They meet our speech and swallow pathologist. And then we get everything set up in order to make sure, that they'll pass muster with anesthesia, that they're safe to go to sleep. And that way we kind of have everything, boom, 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 ready to go. Interestingly, as you mentioned, it's different in each part of the country. South Carolina is one of the few states in the country that you are, I can't say 100% guaranteed, but pretty much guaranteed that you can get dental restoration at the time of the operation. So when we take out the jaw, we put in a new fibula or a scapula, and we put the implants in at the same time. And those patients then go on to get their true teeth.
Yes.
So not every state has that. And part of that is because of our weird healthcare system, which I'm sure other people have probably commented on. It's very strange. But we've been really blessed because I'll have patients come in with cancer and no teeth. And then they leave with no cancer plus teeth. Which is, kind of a nice thing. You're like, okay, we did I can't give you your hearing back because I'm not an ear surgeon, but I can give you some teeth back.
Yes.
But when I was in the University of Kentucky, not everyone could afford the teeth part. So we could put the implants in, but they might not be able to pay $10,000, $15,000 out of pocket expense to get the dental portion done. So then they have these little nubbins that they can't use.
And you say it's quite interesting because you comment about the US healthcare system. Now, the UK NHS healthcare system has its quirks. So does Europe. Each country has its own system. So it, again, being really interesting, being a global community, we are picking up on lots of different themes. And actually, I don't think there is a single country that has it figured out in terms of what the best way forward is. So we all have our different types of challenges and quirks and things. Now, it's really interesting that you just said about you mentioned the teeth and the jaw reconstruction, because actually I'm going to jump to some listeners' questions, and I have a feeling you might have just answered the first one. The first one was, in a jawbone reconstruction for ORN or otherwise, when are implants for future teeth okay to do during the surgery, and when are they not? In what situations would they not be done at the same time? So I guess affordability and insurance cover is one thing, but is there a time where you go, oh, actually, even if we had those options, it isn't the right time to put in the
dental
teeth,
implants.
the dental implants. Thank you.
So for our patients undergoing reconstruction for osteoradient necrosis, so radiation-induced injury to the jaw, we still do make every effort to go ahead and get them restored at the same time, meaning putting the implants in at the same time. We do have a very long course to getting to surgery, though, because part of that is preparing the entire wound bed to be ready. So now we don't want people suffering for extended periods of time to avoid it. But so things I usually will make sure is, one, our nutrition is absolutely optimized, that the thyroid hormone is where it needs to be. In some cases, we'll even get patients into some hyperbaric oxygen ahead of time to kind of really improve the overall tissue that's going to be receiving the graft. It can't reverse completely the bone damage that's happened. And then I usually also will put people on pentoxifylline, which is it's a really old medicine, actually. It's used for smokers who had kind of crampy legs when they walk.
Okay.
And it makes the little blood vessels, or the little blood cells rather, more flexible. So that it improves what's called rheology, which is their ability to do the limbo between tiny, tiny blood vessels. And what that does, and what we've seen, is that can actually really improve outcomes with regards to patient tissue compliance, meaning like the softness and like reduced scar to that tissue, but also overall healing ability. But for the most part, usually we will go ahead and implant at the same time. So it's not necessarily that it's an issue of whether or not it's feasible. But I will say one of the things that has really changed the outcomes is having our maxillofacial prosthodontist in the room, because he's the one that has to restore it. And so a lot of times if you don't have it in the operating room, it can be a little bit nerve-wracking to place those implants and say, okay, I don't know if this is going to do the trick. So he knows exactly where to put them to maximize the density of the bone, the location. And sometimes he'll say, like, I only need 2 here and 1 over here. And so he doesn't do like 1 per tooth. In addition to that, we oftentimes, that little, the picture that I sent you that has the little jaw mock-up. Yep. So that's something that we also use called virtual surgical planning. And that gives us information about the density and thickness of the bone. And that tells us whether or not we can implant at the same time. So in reality, there are very few barriers to the physical action of putting the implants in. It's just whether or not, one, we rehab them appropriately, and 2, how are the wounds? So for people who are at higher risk for wound breakdown for whatever reason, like if we had to get them to surgery faster and I didn't have that lead in with the nutrition and hyperbarics and everything like that, those people I might be a little bit slower to do right out of the gates. But for the most part, pretty much everyone we get in, I actually have, this is me being behind on my data. I just received our information regarding our last couple of years of reconstructions and our percentage of successful restoration. And I want to say it's above 89, 90 something %. And that's for all comers. So I might be higher than that. Dr. Lee will get mad if I misquote it.
Don't undersell.
Don't undersell. But it's quite high. So that's one of the things that I think has really been a game changer. Also, there are now implant companies that sort of cater a little bit more to the different bone that we're using. So for a standard jaw, there's a set implant that works just for that. But for cancer patients, it's different, right? Like if we're taking tissue from the leg or tissue from the side, and it's a much thicker, there's a little bit more chance for contamination, that kind of thing.
Yeah, absolutely. Thank you so much. That's really really insightful. And I actually, sorry, this is totally sidebar. I went to a conference earlier this year, and I listened to a really interesting talk. It was about research and sort of things that were coming up the pipeline. One of the things they highlighted, which was really cool, using Google glasses. Yes. Other brands are available, and an AI, and instead of so the surgeon was explaining that the sort of traditional method is to scan, image it, and then pre-produce your parts that you were going to use. The trouble being that by the time you get to the surgery, things could have changed. So being able to work with these type of glasses that they allow you to cut things to size as you're looking at it. And I just thought that was such incredible development in that area of research, and hopefully coming thick and fast as AI improves and technology improves.
Yeah, and we're going to be giving that a try actually here in the next few weeks. It's kind of it's actually really interesting. It is weird because it's this one's not the one that we were trying out. It's not like a Google Glass. It looks almost like the Oculus, like it's like one of these. And so it's funny because they only had one headset, so we're each trying it at one time. And so you see the person like doing this and then drawing and stuff like that. And I think from a sustainability and a waste perspective too, it's so much better because when we print out the models, one, it's a cost to the patient, right? So, and whether depending on their insurance and everything like that, that can be whatever it is. But also it's plastic, and especially as we kind of looking forward into the future, ideally we want to reduce the amount of extra stuff that we have. Now, the kind of fun part with the printed out ones, I usually will give it to the patient to take home with them, so they have their like their little jaw for home. But certainly we could always print out a picture too. So,
Yeah. Absolutely.
so, but no, it's actually really fascinating that you say that, because one of the places that will oftentimes take bony portions from is from the scapula bone, the shoulder blade bone. And the shoulder blade bone has a really, really thick layer of muscle on top of it. And so when we make these cutting guides, they're almost like little cookie cutters that you put on top and you screw them in and then you cut around it to make a shape. So for instance, like if I have someone who's got a cheekbone cancer, a maxillary cancer, we actually carve it out so it has the opening for the eye and the opening for the nose, and then it fits here. And that can kind of, again, can change over the amount of time. And so, but affixing the little cookie cutter guide sometimes is not quite as accurate because of all the extra muscle and things like that. So I moved to just having them print out the piece that I want, and then I kind of just, basically do like a little drawing around it, and then I do it.
Like a stencil.
Like a stencil, exactly. And so when we were talking with the AI guys, like, oh yeah, just put it on and like you can project your thing on there. You don't even have to like try and pencil it. You just look at it and cut it.
It's incredible.
Amazing.
Also for accuracy, I assume, as well, because if you can preserve as much bone as possible from the donor site, wherever it comes from,
Exactly.
I assume that has a benefit impact
definitely.
as well.
Oh, definitely.
Amazing. Right. So, funnily enough, that next question was, what are there any new developments in the field that you're excited about? Well, that will be one that you're testing next week.
Yeah.
Is there anything else that comes to mind?
Yeah. So there are two others that I think actually one of them may already be up and running in Europe, is ceramic implants. And so there's a company that actually right now they only go to here. So they'll do like the top of the head to about here. They make it's hydroxyapatite and ceramics, like a lovely Italian ceramic for your head. But it actually you can paint it with bone marrow, and then it integrates like a bone rather than being a titanium plate. So instead of being a metal head, it turns into bone. And so one of the things that is kind of the next step for bone regeneration is, instead of having to steal bone from another place, just giving you bone, like a fresh new bone from scratch. And so there are a few places that are doing bone marrow aspirate from the, like they put a big needle in the hip bone, but they don't break the hip bone, so they pull the bone marrow out and mix that with some bone morphogenetic protein, which is basically like a bone growth hormone, and you mix it into like a little slurry, make it into a burrito, put it in, and make a new jawbone. And so right now that's being used in non-cancer cases. And so the next step will be to see, is there a way to incorporate that for either our cancer patients or in the survivorship phase? So after they've already finished their cancer treatments and maybe they need a little extra bone, but it's like a small piece. And so, having to break a bone to repair that might be, less ideal. So, so that part is just, very wild. So yeah, the ceramics and the bone dust is it's quite cool.
Bone paste.
Bone paste.
Bone paste. They'll make it in tubes one day.
I know.
Oh, amazing. So on that sort of same vein, I was just looking through my questions to see if I can, because I obviously didn't organise them. I just copy pasted them out and didn't.
I love it.
Didn't really think about it. But I was just looking through them, and one of the really hot topics, and within the group as well, is about the flap. So having a reconstruction from a forearm flap, and we know we have some people who have a thigh flap, or even using parts of the inside of the cheek, amongst, I'm sure, many other sites available. And the question is always like, we're young, we know this has been. We know this has been done for lots of people who were in their 70s plus, and some of us, diagnosed in their 20s, and you're going like, oh, if all things go well, I have an awful long way to go.
Yes.
So the question is, are these flaps actually gonna hold, and do we need to get them redone at some point? And I guess like, is there anyone holding data in terms of observing what is happening with these flaps in the long term?
And it's interesting you bring that up, because we recently, so I'm part of a head and neck microsurgical group, I guess you could call it, that does a lot of research. And so this one is through the American Head and Neck Society. And one of the focuses of recent is actually what we call survivorship. And that's, like you said, we're seeing patients that are a lot younger, but also we're seeing patients do a lot better. So it used to be, I have got this very, very old book from like the 50s and 60s, and they showed some of the stuff that they used to do. Good gravy. But because they didn't expect people to survive. It was kind of like just get them up and off the table and get them to their life. And nowadays, we're doing so much better. And so I think there is more of a focus of keeping track of that. And if you talk to any free flap surgeon, we all have our lists. Like I keep track of my patients. How are they doing? What's going on next? And even some patients do end up getting toward what we call the survivorship flaps for various reasons. So, for instance, I've seen some patients similarly very young who we stole. It's actually one of my favorite recons. So you do about this little guy right here. So as long as they're not big lymph nodes there, we can actually pull little lymph nodes out and use that to remake the tongue. So you get a little neck lift out of it. And you get a new tongue out of it, and you don't have to have a different donor site.
Yeah. So just for anyone listening who's not watching the video,
sorry.
you were just pointing below your
right under the bony part of the chin. So right
bony part of the chin, just underneath there. Mm-hmm. So wow. So for smaller reconstructions, I assume
you can take a piece actually up to about that big. So
wow.
Yeah, it's pretty intriguing. It's one of those, we always kind of go back to the 1970s hairdos are cool and back in style again. It's funny, if recon kind of does the same thing. We will sometimes look back and go, okay, at the time the way that they used that was terrible, but here's a way we could make a modification and make it work. And so that was a modification done by Chozenga's group, where they took this area here under the chin. So they took skin, a little bit of the fat, a little bit of the muscle, and then one other little extra slice of muscle, which oftentimes has to get moved to the side anyway for the intraoral reconstructions, and found that they do fantastic. And it's a beautiful skin color match, so you can put it up onto the skin here. You can put it into the mouth. Now, the downside being, if you've got chin hair, if it grows here, it grows here, right? And so it grows in the outside, it grows on the inside. So especially for men, we have to go in and do some hair removal down the line.
Yeah. Well, to be fair, we have found, because we've got it with the forearm as well, quite a lot of people with, and it's not everyone, but the majority of people, the hair does fall out within a year. Mm-hmm. So, because I guess it's the conditions, the dark conditions don't allow for a lot of hair growth. So, that's good to know.
Yeah, it's good to know. It's kind of a cool, and it'll turn to oftentimes they'll start to match the inside color of the mouth. It's kind of wild what it does.
Oh, we have some strange ones there as well. We had so mine's like white. It's a completely different color to my tongue. Others have like the red matching tongue tone, and we had someone, I can't remember who it was, but I remember the post on the group. Theirs was white for a good 2 or 3 years, and then overnight turned red. And they went, oh my God, what happened? What's happened? And they put photos up, and we all freaked. We were like, call your team. Go. And it was all fine. It was just something happened, and it decided.
Oh, that's so funny. Well, and I had a very sweet patient that she had on her arm tattoos of all of her family members. So each thing was a tattoo. So there was like her grandparents were stars, her parents were flowers. And so when I was looking at her arm, I was like, oh, good gravy. How am I going to make that work? And so I was like, well, I could go around here and gerrymander all around this area. And what we ended up doing, so finally I called her, I said, would you mind if your grandparents were in your mouth? Mm-hmm. And she said, no, that's fine. So we cut all the way around it, get everything else to match up. And so, but the funny thing is afterwards we were monitoring her. I was like, oh yeah, if you just check the star. So the blood, you can hear the blood vessel right there.
Oh, brilliant. Yeah, we have quite a lot of tongue tattoos, so to speak. I always find that brilliant. And it's always lovely to see with those individuals that the surgeons always had taken great care to, even if they can preserve the entire of the artwork, that it still looked like kind of artwork.
It's still artwork. Yeah.
Yeah, it's really cool.
Oh, I did have one guy that said, kill him and grill him, and it was a deer. And I was like, do you care if that's, and he goes, it's fine.
Yeah, that's
like,
fine.
So just making sure. Just making sure.
Right, we'll go to the next question. So we have someone here, 18 months out from partial glossectomy, followed by radiation. What type of cosmetic procedures are safe / recommended to reduce scarring on the arm flap, and in my case also neck? Returning to the jobs market. Hold on. Returning to the job market interviewing, and turkey neck plus scar is prominent. Overjoyed to be NED, but also self-conscious about scarring loose skin when meeting new potential employers in a competitive environment. Yes, I have been doing lymphatic drainage, massage, etc. So I guess the sort of question is, without giving medical advice, because we never give medical advice,
Nope,
but in
never
terms of what have you seen people do, and also check with your team first before you go ahead. Right, there we go. Got disclaimers 100%. In.
Yeah. So actually, especially being 18 months out, so part of it is you don't want to kind of muddy the waters with regards to surveillance. But there are some things that within the first couple of years I have seen and have been quite successful. So it kind of depends on which part of the problem is the most pressing. So for instance, some patients after neck dissection, on one side they'll have like that saran wrap feel, so where it's really sucked down on one side and then the other side's normal. So for those patients, I have seen fat grafting. Essentially taking fat from another site, liposuction, it's then very finely minced, almost into like looks almost like a custard. It's really lovely, actually.
Very finely.
Yes, very fine. And then that's actually injected just the way that you would do for facial fat rejuvenation. What that does is it makes the skin over top of those areas slide a little bit more easily, because fat is so lovely, except for when you're trying to put on tight jeans. It's so lovely, so regenerative. Has lots of growth factors in there as well as stem cells. And so what that can do is really help to loosen up that saran wrap feel. The other thing that can be done for those areas, so especially if like one side is the untouched side, right? So you've got the one side that's been operated on, then the untouched side. I have seen also dermal fat grafting, and again, that one is at the the discretion of the surgeon of moving the actual skin and soft tissue over. So essentially kind of doing, as we talked about when you use the flap from underneath of the chin, the turkey waddle. So you can actually reposition the turkey waddle to a new spot. So by moving that tissue over. Typically that won't impact surveillance and things like that. But again, at the discretion of the surgeon. Other things that can really help.
Is that quite invasive? Because I can imagine the other thing, you take it out your back, you mince it, and then you inject it. So it's no different to any other type of filler. Mm-hmm. But to move from one to another, do you have to reopen everything again? Or?
It is. So it's essentially like a neck lift. And so we call it adjacent tissue rearrangement. And I have done it for patients before who were well out from treatment, and sort of similar thing, because occasionally even getting pain with it, even with lymphatic drainage. And so that can kind of help to reset things.
Sorry, I am really asking for selfish reasons here, because because that's one of the things, like they basically on one of my sides did a really great job, because I had a really lovely lift, because I always had a double chin here, but I still have my double chin on the left hand side. So most people don't notice it, but I notice it, and especially on photos of things, I can always see. I'm always one side heavy, so it's just like, can we just push some over? So it's really interesting. It's interesting to know. I must admit, I personally probably wouldn't do anything about it, but it's interesting to know that you can. You know, that is even an option. Of course, with affordability and so on.
Absolutely. Yeah. And then there are a few that are non-surgical options, and the data is a little bit mixed, and it kind of depends on the equipment. So one of them, which I do actually recommend as it just feels good, not as no, not medical advice,
Yeah.
but it's actually quite lovely, and I have one. Is actually red light therapy, especially if in the winter months. So red light therapy or photobiomodulation is another name for it. Has been shown to help with chronic pain, scarring, also wrinkles, which is one of the reasons I like to use it. But it's lovely. You can get just a panel off of Amazon or something. Although I also do not approve of marketing, so I'll say red pill from somewhere. Yeah, we can
from somewhere.
Yeah, from somewhere.
Yeah. Well, I have seen those masks before with the red light behind it. So
and honestly, the panel actually works just as well. So you don't have to drop $700 for a face
mask.
And then the other one for so one of the potential risks actually with a lot of facial rejuvenation things is facial fat loss. And so one of the things that you can also do, let's say if you're feeling like one side is more full than the other, microcurrent does reduce some of the fat cells in that area and can give you the snatched feel on the one side. Definitely not on the side that's been operated on, for sure. But on the non-operated side, that is something you can consider as well. Again, not medical advice, cosmetic advice. But
cosmetic, to even it out. We also know that a lot of our patients feel self-conscious after radiation, because what can happen, especially like I've seen it around the lip area, where the skin, it all gets a bit loose and it almost scrunches up. So skin, I can describe it is as if this patch quicker. And actually it wrinkles in a way that isn't necessarily natural either. And there has been a lot of talk on the group about Botox. And to be honest with you, a lot of people don't get the advice from their team because they don't talk cosmetics.
Right.
Especially if you're in a health system like the UK, you then have to go to a private practitioner and you're never quite sure who you're meeting. So what would your advice be? Maybe more like how to research and how to find the best advice on what is a good idea and probably not such a good idea.
Yeah. So one of the things that with regards to picking, like who do you know that is going to do a good job? So unfortunately, there's not like a great what's it called, Yelp for plastic surgeons and things like that. But a lot of the facial plastics and reconstructive surgeons through otolaryngology are a bit more keen to the sort of nuances and underpinnings of cancer surgery because they do training with head and neck cancer prior to doing their facial plastics and rejuvenation. So sometimes when it's a purely cosmetic plastic surgeon, they might not have seen as many head and neck cancer patients. And so I think that's one thing that can be quite helpful. And I always tell people, I said, if it seems like it's too good to be true, it probably is. So they're saying like, inject salmon semen or something into your face. I would just,
Yeah, I have seen that. It's on a show. It is salmon sperm.
Yes.
Like, under your eyes.
I'm like, oh gosh, like please don't. I'm like, please don't. And so, interestingly enough, one of the places that I think if you're looking at social media and things like that, Reddit actually has some of the more probably like well-researched reviews that I've seen online, because every now and again I'll go and check. I'm like, okay, someone's talking about this like $2,500 face like home laser, and I'm like, this seems not quite. And then someone's like, oh yeah, I went through and I looked at the actual laser specifications. This is not even a laser. This is an LED light, and da da da. So I think I feel like a lot of the Instagram ads and Facebook ads and a lot of those ads sometimes can be very misleading because they'll show you all these pictures of things. So one is you can always check with your team. So sometimes they'll be like, oh, I didn't even think about asking you about that. And that's honestly, to play devil's advocate, I think it's one of those things again that as a woman, I also am very sensitive to how I look and how I present. And so when people come in, I'm like, how are you? And they're like, I'm okay. I'm like, but how are you? Like what's the thing that's limiting you? Are you still doing the things that you want to do? Are you able to go, go to your book club and feel comfortable, or you're going to have cocktails and you don't feel weird about eating in public and things like that. And so I think that especially with the younger generation, we're starting to see people be more aware of it. To put a shameless plug in, one of my colleagues actually runs a research consortium right now, and he has this project called Bright. I forget what it stands for. I'm the worst. But it's lovely. And so patients with essentially there is a set they're set video visits, and so they can be in person as well, but there is a medical provider, so it's either an APP or a nurse, who calls the patient every so often to check in. And so it's actually a randomized one. So you are either randomized to just chatting with someone about how things are going, how life is, how, like we talked about, are you going to book club? Are you going to, to parties? Are you taking pictures and sending like your Christmas photos, things like that? And then there's the other part of Bright is actually a set thing. Like, we're going to talk about, how do you feel about your eyebrows? Or, like there's like a very set thing. And then I want you to focus on, I am a survivor. I have survived. I am beautiful. Like, just like things that, you feel a little goofy saying them, but because it's part of a set therapy, I think it does really make a difference. I don't know what the final results are yet. They're still, it's still ongoing, but talking to patients on the side, I've heard really good things.
Yeah, no, absolutely. And I do feel like, I feel like, the first couple of years are difficult because everything's acute, everything is new, there is so much information, things are changing. And also I always feel, no matter if you've had surgery, radiation or chemo, or everything, all of the above, or one or two of them, the first 2 to 3 years there are bumps, lumps. It's a really bumpy ride because you're constantly worried about recurrence. And to be fair, and I'm coming from a UK perspective, the team that you see, that's what their focus is. It's finding any recurrence. So it does become more tricky the further you come down the line, and you suddenly go, oh, there's small things, but things that bother me, to bring them up, and how to bring them up with your team, and with who to bring them up. And I've still not come across the best way of doing it. I feel like having the peer-to-peer support helps, because we encourage people to speak up and empower and think about ways how to go about it. But it's very difficult in a cancer setting to bring up something cosmetical, unless it is very severe. So I hope that as a community we can maybe talk more about that, and staying on, as I have you here, on the cosmetic side. So our listener also asked about scars.
Yes.
So I used silicone plasters for a long time.
That's a perfect one. Yeah.
And massaging. However, and again, I'm taking my own experience with what I heard, especially when it comes to forearm flap and facial scarring, because the nerves and everything is a little bit mixed up. So I personally find it really difficult to touch my arm, because when I touch my arm here, I feel, and I'm pointing at my wrist. Pointing at my wrist. I actually feel someone grabbing my thumb.
Yes.
So it makes me feel really queasy. But if my husband massages my arm, I'm fine, because it's like,
you don't know where he's going to be touching to.
I don't know where he's touching me, so it's fine. So and then it actually can be quite enjoyable. So I guess if you can get someone else to massage an area, great. But some people won't have that. Do you have any other sort of tactics or techniques or things you can do for scar management?
For scar management. So the silicone plasters are a really great tool. The red light is another one that actually can help with that scar. And then there are a few actually ring massagers. So it looks like a ring. And then on the inside, there are little rollers, and you actually put your arm in and out of it. So you're not having to do anything where you're physically touching the area yourself. The microcurrent can be a little bit weird because it does activate nerves sometimes, so it might make your hand feel on fire. But some physiatrists do use like electrical stimulus there. And then this is another spot actually that can be amenable to fat grafting as well. Because part of it is the distance between the skin and the nerves is a lot closer because of the skin grafted area. And that's been another move that we are trying to make from the reconstructive side, is that now we're moving more towards what are called the lateral arm flaps. So you don't have to usually have a skin graft there. Or one of the things that I've moved towards is so in the US we call them bingo wings. So when you say bingo and you got a little wing here.
Little wings,
Little wings. So we actually now take the skin graft from here. It's a bit thicker, and so there's a little bit more space to kind of help keep that area from sinking down quite as much. But I would say, the plaster, the silicone plasters, the red light, the ring massager, and like I said, you can look at talking if there is a physiatrist or physical therapist. They may have some more things to do for this area as well. It might be occupational therapy, actually. And then also, I will make my plug for acupuncture. So I'm incredibly lucky. We have a lovely gentleman, Dr. Bunt, not like the cake, like Bunt like the ball, like a cricket. And he so he was military trained, and then trained. So he's family medicine, but also does acupuncture. So he does it for a lot of these sort of like weirdly re-innervated areas that are not quite back to where they need to be. And in addition to that, he also does acupuncture for dry mouth. So he does it's really lovely. It's kind of wild. It goes in your ear.
Yeah. For anyone listening, I just pulled a face like going, oh, dry mouth. There's going to be a lot of chatter about that. Everyone's going to be ringing around. Do you do acupuncture for dry mouth? Because it's such a plight on so many people.
It really is. And it's part of my practice is the salivary practice. And one of the trials, and I don't know if it is across the pond just yet. It's I'm blanking on the name. It's a scope that goes into the salivary glands, and then it deposits basically like a gene alteration medication to help re-up the salivary production on patients who had radiation.
Yes.
So that's hopefully coming in soon.
Yeah, haven't heard about that one yet, but I'm sure if it might be on its way. If it's in the States, then it's always on its way. Eventually. With the scars, what I also find quite an interesting question is when to start, because we have people are fresh out of surgery and they're really keen, they want to do things straight away, but you're also like, we need to let things heal. Then on the flip side, so I was a bit unlucky, so my healing period, COVID hit, so it was very much like in and out, but nothing else.
Okay, bye.
Hello, bye, go get out, which I was fine with, but I then didn't mention the scars, and then by the time I did mention it, it was like, wow, you're quite a bit down the lane. So my scars are rock solid, basically. So it's way too late to basically intervene unless we do the whole thing again and remove it all. And I was like, no, I'm good, thank you. So but from a timeline perspective, are there any sort of common sense approaches of when is the right time to start thinking about doing some stuff for your scar?
So usually about 2 weeks after surgery. Now this is kind of more for like if you were just getting neck dissection, no free flap. So right about 2 weeks after surgery, I usually will have people start using the silicone plasters. So right out of the gates, or silicone gel. So there's also a jelly form that can be used. I usually have people start doing that right away. At the 2 week mark, I also will have people start doing their stretching, because part of it also is kind of getting everything moving and the blood flow going to those areas.
And that's neck stretching for those listening.
Oh, yes, I'm sorry. And I talk with my hands like, I'm like, and then you do this. And then for the arm, usually I usually have people wait about 3 weeks, because the skin graft does take about 3 to 4 weeks to really, really get to become a part of it. And you don't want to move that too much, because you can get a tendon exposed and get some really big scar tissue there.
Yeah. So you want to make sure it's fully closed. So actually, for me, it took 9 weeks.
9 weeks. Oh my goodness. Yeah.
Yeah. So obviously, I'm a very slow healer.
Oh no.
But yeah. So once it's fully closed and you feel like nothing's gonna pop out,
Exactly.
that's maybe the time to think about that.
And then after radiation, because everything is usually very raw, very uncomfortable, I tell people be gentle with yourself. But the biggest thing is, again, doing mobility. So because one of the things that will oftentimes happen is that you're so you feel like you need to stay very tight, like a small little ball, after all of the things that you've gone through, that it's like hard to unravel all of those things. And so that's where gentle heat, or cool, whichever actually is more comfortable, honestly. And then moisturizing. So and I'm sure that's probably come up quite a bit, but moisturizing it was so funny. One of our radiation oncologists, I love him dearly. He was on the old elder side. And he was like, well, they can just use peroxide on their neck. And I was like, that sounds terrible. No, we can do a water-based gel. Like, oh, let's not dry it out anymore. He's like, I never thought about it that way. I said, yeah. He's like, well, I don't want them to put anything that's going to burn them from like I was like, oh, that makes sense. That means we'll do water-based everything.
Lots of water-based creams. That's one of the main questions when someone is starting radiation. And actually, we've had, I can't remember off by heart, but we've had lots of recommendations of people starting moisturising before they start radiation.
Yes.
And then keep going throughout. And some people have had some really good results in terms of the burning, or the internal burns. You can't really
it's hard to
do that much about, but at least to reduce the blistering on the outside. So and the other one too is aloe vera. So the in the States they actually have some drinks that you can do, which I had never seen before, but the actual plant, if you just scrape the plant, and it's all water based, so that's also a nice soother one in the mouth. And then for the thicker scars, the other thing that you can do once sort of everything is over and done with is actually so it's a derma roller. So it's a not a very deep micro needle, and you can look at the various sizes that they have, but that's another one that can actually help break up scar tissue. In some patients, if it's very, very sensitive, we can sometimes do like a light numbing cream on top of that first. But a lot of times it's more just kind of breaking up that scar tissue very gently. So it's not like the ones that the vampire facial or anything like that, which sounds very scary. But that is one thing that can be used to help break up some of that scar tissue as well. And I'm just thinking we need to also mention this. We are talking about healthy scar tissue here. So not anyone who's got any conditions that makes them scar. There's it begins with K and I can't remember it right now. Keloids. Keloids,
That's
yes.
it. You've got it.
Where the scars are really... One. That's a different one because it gets bigger and that needs intervention by your team, which quite often is a whole host of different things, including steroids. But
steroids and things like that. Yes, exactly.
So so thank you so much. That was really interesting. Like amazing. Just going through my questions. Oh, there was one other cosmetic one. Facial hair for women.
Oh yes, yeah.
So, and actually, I'll put my hands up. I'm a lady with a beard, and and before I had cancer, I used to go and wax religiously. The trouble was, it took a long time before I could go back again, before everything had settled, and then I got an infection, which gosh. I mean, it was great because it got rid of all the scar tissue underneath, but I also might have not realised I had an infection for a really long time, and it set me back by quite a lot. So I am extra careful, and also my practitioner, bless her, she's really, really careful.
Oh, good.
But it means that I can't wax as much anymore, right? And it means that there's like a period of 1 to 2 weeks, which is really uncomfortable because I know people can see it. It doesn't, depending on the lighting, it's like, oh God. And obviously there are things like laser therapy for those with dark haired skin, and there's a thing called electrolysis. And we have had talks in the group before because we weren't sure how safe they are, especially if you're missing some lymph nodes or might have been prone to lymphedema. Again, where would you go for advice on that? If
that one, I would probably also talk with the facial plastics and reconstructive surgeons, because they're the ones, again, that they're going to be a little bit more keen on the kind of most up-to-date knowledge for that. So some cosmetologists, they, especially if they work primarily with cancer patients, a lot of times they will have a lot of knowledge regarding that. But if you're going to be doing something like electrolysis or IPL laser, which is something photo laser for the eye is, but it's another type of a laser for hair removal. Those do tend to be fairly low risk, but again, I would probably check with the facial plastics and recon people. The electrolysis and the IPLs, I think IPL has a lower duration of effect. The electrolysis can be permanent, but again, I would talk with one of the FPRS people.
It seems quite invasive as well, because electrolysis is the little hot iron that goes into your hair follicles. I can only imagine, ooh.
I know, and I think they grab it and electrocute it. Yeah, they grab it and electrocute it. Yeah.
So, oh my god.
I know.
But yeah, I'm actually looking into that one at the moment, but we'll see. I still need to speak to my team.
Well, yeah, I've got the one that comes out here that can get really quite long. So I'll be thinking one day, oh no, it's back.
It's back. That's all right. It's all right if you have one, but mine is built up now to a point where I'm like, okay, this needs to be nipped in the bud. It needs to go. Right, so we'll just finish up with a couple of more questions, and then I have a main question for you as well. So there's a I'm going to summarize these questions because they're about you choosing your profession.
Oh yeah.
So the first one is what mental and physical skill do you need to become a surgeon, and what's the toughest surgery that you feel you've had performed in the past, or what is the most what do you feel is the toughest surgery? And the final question in that set of three is, and I don't know if it applies in the US, but in the UK, once you become a surgeon, you drop the doctor and you become Mrs. or Mr. again. So I don't know if that applies because you're doctor, so that's fine. We'll leave that.
Well, as I say, I do have some patients who just call me by my first name. Sometimes I'm like, oh, are we there already? Because I'm still calling you Miss So-and-so, but okay.
I do this. I always come in, I go, I'm Barbara. Don't just, who are you?
But yeah, it is kind of funny. So there was a study in the U.S. looking at how professional does someone appear to you, and they said that the most professional one was a man, of course, wearing scrubs and a white coat. And then the next one was a man wearing a suit and a white coat, or no white coat, just a suit. And then the next one was a woman wearing scrubs with a white coat. So I was like, perfect. I can wear pajamas to work.
Fabulous.
And people will think that I'm I'm for it. I'm like, I don't need to be getting a expensive tailored suit. So I'm just gonna get my lovely pajamas, lots of pockets, so many pockets that work. So
amazing. So so the question was mental and physical skill to become a surgeon.
So I will say one thing that I think is probably the most important is having being a cautious optimist. And so I know it sounds kind of strange, but you can't be a cancer surgeon and just say, okay, I'm done for the day. It's not like I'm going to go make a hamburger and leave. Although sometimes it feels like that when it's a really big function. No, I'm kidding. But it's one of those things where you have to believe in what you're doing, always wanting to advance to the next step. What is the thing that I can do to make this person's life better? What is the next thing that I can do to make their suffering less? What is the next thing that I can do to make it so fewer people have to go through what I'm doing to this person? If I can make myself obsolete, that'd be amazing. That's part of what we do research for, right? I'll just go do Botox all day and fat injections. Yeah. But that's I think that's part of it, is that one is having the hope to do it, because I think once you don't care, once you're like, okay, this happened, fine, whatever, I'm just going to go on my next thing. I think that's when you stop being a good surgeon. So we take a lot of it home with us. You know, my husband gets irritated because he'll be like, I'm asking you a question. He's like, I'm never going to be more important than your least important patient, you know? But it is something that we're always thinking about. And so you can't let it take your entire life over, of course. And there still has to be a balance and a compartmentalization. But I think that's probably one of the biggest things. Like I said, there's we all keep lists, you know, in our heads or on a computer or whatever, of all the patients that we've taken care of. But there's this French surgeon who said, you know, every surgeon has a graveyard in his heart or in his soul that he goes back to and visits and he mourns. And because, you know, every person I take care of, there's a lesson there to be learned and to be used for the next person. And so I think that is probably one of the biggest things. The other one, of course, is, you know, hand-eye coordination. But
yeah,
but you figure that out really early on. And it's funny because, you know, like I was telling you, I have a bunch of engineering family, and they are very, you know, mathematical. They'll tell me exactly what angles things are. And I was a liberal arts major. Like I love science. Like I said, I love it. It's one of my favorite things. But I love the squishy bits of science. So when I'm planning on something, it's not necessarily like, oh, okay, I need a 15-degree angle here or 20-degree angle here. I say, okay, I need to make the cut so that this matches up with this. And it drapes in such a way that the tongue still moves, the lip sits here. And so it's really fun in that whole kind of conceptualization of how do you make it so that it looks good and works well, because it's a balance of oncologic outcome and functional outcome, because we want to make sure that we do right by both things, right? So very, very fun. And also bladder control. I can go like 12 hours not going to the bathroom.
Sorry, I'm laughing because I was like in deep concentration, then went, oh, bladder. Oh, yes, of course.
But yeah, it's really one of the things I love about head and neck in general is it's very collaborative. It's very much a team sport. So we have like I said, we've got the recon surgeon, the ablative surgeon, we've got the max fax guy, we've got the prosthodontist, anesthesia team, we've got our nurse, circulator, and our scrub nurses. We'll oftentimes even have like the reps who are helping us with, you know, the various gadgets that we're using, and it's all hands on deck, and so it's a really collaborative, lovely kind of interaction that happens to get the job done. And usually the patients are with us in the hospital about a week, so that, you know, it becomes like, yeah, there's Barb. Hey, Barb, how we doing? You know, so everyone gets to know each other quite well, and that down to like the floor nursing and the techs who help get people up, and our physical therapists. So it's a lot, but we have such a great team that it makes going to work really fun. I've never been like, oh, I don't want to go to work, unless it's one of those things where I have to watch a training online or something like that. But it is really nice that each day is it's a new puzzle. And then the other great part is on the other side when we get to see people back. And one of the things that like I said, my maxillofacial prosthodontist, who I'm absolutely obsessed with, he's so lovely. He'll send me pictures afterwards of like, hey, look who got their teeth, or look who got their ear, look who got their nose. And it's just lovely seeing that, you know, going from like, you know, we got you past this big part of it, and then getting on to like, okay, I'm back to playing pickleball.
Oh,
you
wow.
know, I'm back to eating
amazing.
hot dogs or whatever.
Yeah. Oh, that's so lovely. And actually this feeds perfect into how I wanted to wrap today up. So I really think one of the things that has really shone through our conversation and my interview with you, shall we call it that, you are a leader within your community, and you've done that by spearheading a project that aims to bring together female surgeons. Now, can you tell us more about it, and also what inspired you to bring this group of people together?
Absolutely. So it's, you know, even though we've made a lot of strides in medicine with regards to women representing various subspecialties, head and neck has lagged a little bit behind. It's definitely changed over even since I started. But one of the things that I think is sort of unique, and this may paint me in a bit of a sexist light, but I do think that I've seen a trend of it, is that women tend to be more open to sharing about if something's good or if something's bad, or if they have questions. I think we're more likely to second guess ourselves, even when we're right. And we're more likely to reach out to talk to others for support and more likely to benefit from it. And so I think that's changing for as the younger generations come up. And I think people are more in tune with like, okay, I need to actually talk about what's happening. You can also see the backlash with lots of toxic masculinity and things like that. But one of the things that I noticed was that even though I had lovely mentors, I absolutely adored them. They're wonderful people. They were all men, and they're fantastic. I mean, they taught me how to do what I do. But one of the things that would come up sometimes I'd be, doing a surgery and I'm like, okay, I did the surgery. I did a really good job. And then you start sitting and thinking about it. What if this didn't go well? What if this part, or what if, now I'm sitting here worried about, should I be worried about this? Is this something that I should be thinking about? Am I over worrying? And so a very good friend of mine who had the same sort of pattern that I did, almost to the exact, wanted to do neurosurgery, switched at the last minute. We connected and we would do our own mini tumor board, our own mini debrief, pretty much every single day. And via an encrypted app, of course, never using names or pictures. But it was such a nice way to sort of begin to debrief. Like, okay, here's what I was thinking. I brought it up to like maybe someone else and they kind of brushed me off about my concern, kind of talking through things. And even getting scientific articles. So it'd be like, I was doing this. Here's what I was thinking. I haven't found what I'm looking for. And, she'd send me paper. I would send her paper. So then my very first job, which was back in 2015, it was not a great job. Unfortunately, it wasn't a good fit for me. The support wasn't where I needed it to be. But I learned a lot. And I learned a lot about what to ask for, what to expect, and about my own worth as a person. And so when people were interviewing for that job, I was like, y'all need to call me first so that we can talk about that. And to say, what things do you need to ask for? What are things that I wish I had asked about? And then when I subsequently asked for it later, they said no. And so so the first person was Rusha Patel, was my little buddy that we kind of talked to every single day. So then the next person was Caitlin McMullen, who's phenomenal. She is head neck surgeon, a lot of focus on endocrine cancers, so thyroid cancers and things like that as well. So she was going to interview for that job, and I said, let's chat. So we met for drinks, and I talked with her a little bit about that. And so then I included her in on, I told her like, oh yeah, I talked to my friend Rusha every single day. So then all three of us were together. And then we're all talking together. We're like, this is really good. This is a very good thing. How can we make this be more? And so then we started inviting other people. So then we invited another woman who actually interviewed for my job as well. And then after that, we actually invited a Max Fax person, Dr. Chi Viet, who is she's amazing. She's got several actually RO1, so NIH, the National Institutes of Health, grants in oral cavity cancer, as well as oral cavity cancer pain and things like that. She's amazing, and also an amazing cook and mom and all of the other things. So she joined, then she brought more people in, and then we brought more people in, and then we'd meet people, and it was so funny because we would be chatting about it at meetings and hadn't met each other in person before, right? Because, that's how it works sometimes. So we'd be at meetings, and everyone would be like, well, how do you guys know each other? Like, oh, we have a WhatsApp group. And they were like, well, can I be in a WhatsApp group?
It all starts with WhatsApp groups. Everyone wants to be part of the WhatsApp group.
That's right. And they were like, no boys allowed. So, Yeah. And it ended up, it just sort of expanded from there. We're now at 108 members.
Wow.
And so some people are, I call them, some people are, they're kind of, they look and listen. They don't necessarily like chime in all the time, but one of the cool things is that people will talk about their wins. They'll talk about when they have troubles. They'll talk about, hey, I did this research, or even I'm negotiating a new contract, or I want to take maternity leave, or actually there was an entire thread about red light. I'm not going to for the wrinkles though too.
For the wrinkles. That's amazing.
Yeah,
fantastic. Well, you're going to have to share this episode into the chat and go,
absolutely.
Girls, listen to this.
Yeah. So it was really lovely. And actually from that, I've been working on collecting all of the publications that are cross-pollinated because of that group. And so I have 108 individual bibliographies on my desktop right now that are all the women that are in this group who have published. And like I said, Dr. Viet at Loma Linda, she has an R01 grant. I think Dr. Thomas has one with her, Krista Thomas, who's at University of Colorado. We've published several articles together on parental leave for surgeons. So there's really been this huge kind of, morphing, and it's really nice to kind of step back and like watch everybody interact and grow and learn and refer back. They'll say, oh yeah, if you search for this, you'll see I shared a paper about this technique and that kind of thing. So I think it really has changed the way that we approach that peer mentorship. It's like you never see anyone belittling anyone. You never see anyone being like, wow, that was a dumb thing that you did there. It's all like, you did the best that you could, or you are doing amazing. Look at you. Congratulations on your publication. Congratulations on your promotion. And so I think, as you mentioned, peer groups are so important. Mm-hmm. Hopefully at some point we'll get our website up and running. We've been talking about it for a long time. Someone was like, we should get a website. I'm like, yeah, we should totally do that.
I feel your pain. I'm trying to get a new website up and going for Young Tongues, and it's like, it's just like pulling teeth at the moment. But yeah, no, absolutely. That is it. Is so amazing, and I know all of our listeners will love hearing that exists, because it's really weird. We're kind of part of the same community, but in very different ways, because we're the patients, you're the clinician, and I think as an organization, the Young Tongues, our primary function is to provide the peer-to-peer support for patients and their carers, but we have other aspirations beyond that, and we have charitable objectives that we have to fulfill beyond that, which includes promoting collaboration amongst healthcare professionals and providing education materials when it comes to treating young people. So I was so excited to hear about your network, because I thought actually that's the ethos of like we're quite similar in terms of our values, and I think that's really exciting. So hopefully there might be some cross-pollination.
Yes, absolutely.
And working with patients and clinicians, what that will look like, who knows.
Well, I was going to say, one of the things that when you were talking about how do you bring things up with your clinician, and one of the objects of the Bright study, I think, was to kind of address some of that. But we have in place through the National Cancer Centers, we have these it's a thermometer, a distress thermometer. Mm-hmm. And it's something that's like, are you distressed because of, gas prices or whatever it is? But that might be one that, could pollinate from the Young Tongues, is that, hey, can you make a little questionnaire that when we're coming in for our follow-up visits, I want you to ask these 5 questions. Mm. And that makes it easier. It opens the door for you to say, hey, I feel great. I don't have any cancer, but I want to do something about this. I want you to do the next step. So that could be the Young Tongues questionnaire. Yeah, no, absolutely. I actually am thinking already beyond that, to be honest. So I've got this vision, and I probably shouldn't say out loud, but I will. You have to manifest. I'm manifesting it. But we have so much other things to do first. But the sort of big vision for the future is that one day we'll have the resources to bring all the different stakeholders into one room and have a really honest conversation, kind and honest conversations, mm-hmm. from the very different points of view about what does best practice look like. Because as a patient organisation, we are seeing such vast variations, mm-hmm. In geography, but also within countries and even within hospitals. It happens, but it's also really difficult for us to educate patients in terms of what their expectations should be and how they can empower themselves, and what should be like an absolute minimum, mm-hmm. and what is go over and beyond. And it's a very difficult thing to define. But at the same time,
we feel that sometimes there's a missing conversation amongst the specialist expertise profession that actually also has to take place. And then the patient view, the policy view, the finance view has to be fed into that as well. So I do hope that in the future we'll get to this sort of round table effect of being able to have these really open conversations. We will need a massive conference centre and about 5 months. Maybe it's going to have to be some sort of annual, like the G8, but for tongue cancer patients. I don't know.
I love it.
But whatever that will be.
Have suitcase will travel. So I'm always happy to.
Yes, absolutely.
We actually do have upcoming, and in March there's a group it's all HPV related cancers. So like top to bottom, the whole whole 9 yards. And that one that's part of it is also survivorship and things like that, early detection, blood tests, all of the things that that need to come in. But I think having a patient perspective portion would be really, really valuable. So
and I guess it's really interesting because in that sort of sense we are really niche, right? Young tongue cancer, cavity and base of tongue. But also what makes us unique in the sense you just mentioned HPV. HPV is actually only 10% present within our community.
Within the group.
Yeah, within the group. But when we go on to the outside world, HPV is the 90%. So it's like, oh, okay, no, we're fully behind that, supportive of that. But we're here.
Yes.
But we're here as well. So, so it's really interesting. Anyhow, we digress. I just want to say, Alexandra, thank you so much for joining us today.
My pleasure.
I've learned so much. There was so many things I wasn't aware of that we can do, and I'm so grateful you mentioned them on this podcast.
My pleasure.
And I'm sure our listeners feel the same. Thank you to our listeners for joining us again. Don't forget to follow us on social media at Young Tongues Global. If you want to come onto the podcast to share your patient story or your expertise, send me an email to podcast@youngtonguesglobal.com. Like always, give us a nice review. It really makes a difference. And that is all. Thank you so much. Have a fabulous week.
Thank you so much.
And we'll see you later. Bye-bye.